It's Dr. Sabrina Siegel here to introduce a brand new special series brought to you by the NEI podcast. Welcome to the PsychopharmaStahlogy show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts with 1 part released each month. The second theme we're addressing is on treatment-resistant depression and suicide prevention. And this time, we have some special experts on the topic joining us. Let's listen in to part 2, Shelter in Place During the Storm, Mental Health Consequences and Suicide Prevention During the COVID-19 Pandemic with Dr. Roger McIntyre.
Hello, this is Dr. Andrew Cutler, Chief Medical Officer of the Neuroscience Education Institute, with another episode in our podcast series called PsychopharmaStahlogy. And joining me today are Dr. Stephen Stahl. Welcome, Steve.
Hello.
And our friend Dr. Roger McIntyre from the Great White North. Welcome, Roger.
Hi there, Andy. Good to be with you and Steve.
Yeah, and we're doing a series here on suicide prevention and the idea of suicidality, and never has it been more timely, I would argue, than during the COVID-19 pandemic. And so the title of this is Shelter in Place During the Storm, Mental Health Consequences and Suicide Prevention During the COVID-19 Pandemic. Obviously, the pandemic has amplified a trend that has been going on for some time now. Roger, can you tell us a little bit about this trend with suicidality and especially what's happened since COVID-19 has hit?
Yeah, absolutely, Andy. COVID has had, really, if anything, it's laid bare and exacerbated some of the risk, not just for mental illness, but suicide around the world. It's often stated that there are about 800,000 people who commit suicide each year. That's according to the World Health Organization. In the United States, suicide is the 10th leading cause of death. It's the second leading cause of death in younger people, for example, under the age of 25. This is a common event, and the trends around the world in some ways have been a good news story. There's been reductions of suicide in some parts of the world, like India and Russia, but we've seen actually a steady increase in suicide during the last 2 decades. According to the CDC in America, deaths of despair linked to depression, unemployment, opioid, alcohol misuse, and people are aware of that. And that was the prelude, if you will, coming into COVID. Mm-hmm. And what COVID did is it created not just a public health crisis, but a mental health crisis and an economic shock like we've never seen in our history books. And already, people know what's happened is it's increased the risk of mental illness, like depression, which is the most common condition associated with suicide, but it's also increased suicide independent of depression in some parts of the world. And I think this is speaking to some of the risk that's been amplified in some parts of the world. So it's tragic that we are seeing risk elevation and we're seeing suicide elevation in some parts of the world now. But again, coming into this, there was already a rising rate in America for 2 decades.
Steve, what are your thoughts on this?
Well, I noticed that the topic is suicide prevention, not suicide prediction. And so we tend to think of suicide because it's a very personal thing and it happens in specific patients that we know. And there's an old saying, there's 2 types of mental health professional, one who's had a suicide in their practice and one who's going to have one in their practice.
Yeah.
So we tend to think of individuals, but suicide prevention is approached as a sort of a systems approach to the body of people who are available to commit suicide. And that's actually why COVID has been so bad, because a pandemic works at a macro level. And our prevention efforts are also, will filter to an individual, but they really are at a macro level because we can know who's more likely to commit suicide. It's just a little bit like the public health approach to whatever, hypertension or dyslipidemia. We know that if we give a whole bunch of people treatments, that there's a lot less heart attacks, let's say, that's going to occur. But we don't know whose heart attack we're going to prevent or when that heart attack is going to be prevented. So we need to look at this not as targeting specific individuals so much as the society in which this pandemic is occurring.
Certainly. And we do know some factors that are associated with suicide, which as Roger said, have been amplified by COVID-19. We certainly know that there's financial issues, certainly in the westernized world, loss of employment, the psychosocial issues of isolation, change in our relationships, things like this. So clearly, these are all things that also heighten the risk. Historically, Roger, if we go back to one of the first coronavirus epidemics, the SARS epidemic, which I know hit particularly hard in Toronto in 2003, yeah. What do we know about the relationship between suicide and the SARS epidemic?
Yeah, what we do know about the SARS epidemic, and this could even go back to the Spanish flu, I think everyone during the last year has gotten a history lesson of infectious diseases and when they occur.
Yeah.
But we saw increases in rates of suicide after SARS. That was reported in Asia and, of course, in Toronto, which was the city most affected outside of Asia. That was also reported after the Spanish flu. And there's in population health, they use a word called syndemic, S-Y-N, syndemic, a synthesis of more than one epidemic or pandemic. And we really have two pandemics. We have this COVID-19 pandemic. We also have a loneliness pandemic. And loneliness, Andy, you used to be a DJ in a previous life, and you'd know Roxy Music. Brian Ferry said in one of his famous songs that
one of my favorites.
Loneliness is a crowded room, according to Roxy Music. And if we use validated scales, like the UCLA loneliness scale, it turns out that about 1 in 4 people reach and exceed threshold for being clinically lonely. And to be clear, loneliness is not synonymous with being socially isolated. They're correlated, but quite different. In loneliness, I think social isolation is quite obvious. It's your proximity to people. But loneliness is subjective. It's about to what degree is your interpersonal connection aligned with what your expectations are and needs are. And it's interesting because what we're noticing is that younger people especially reported loneliness coming into COVID. And what's interesting is that younger people especially are reporting worse mental health in the context of COVID. People often think it's the older population. Actually, older population is doing worse off from a physical perspective, but with the virus, et cetera. But younger people are doing worse off from a mental health perspective. And to be clear, there's never one factor, but there are macro factors and there's individual factors. And one of the macro factors I really believe is the exacerbation of loneliness in this population.
Yeah, and that certainly makes sense. Speaking of Roger Ferry, of Brian Ferry, he also said, if words could talk, I wonder what they would say. Which is one of my favorites. Yeah. I want to refer to a recent study that was done in the UK, and this looked at the first month of COVID-19. An increase in self-harm and suicidal ideation was reported, with a really surprising 25% of people stated they had engaged in self-harm in the last week. That's really shocking to me. Steve, what do you make of that?
On the surface is a little bit hard to believe, but that's what the study showed. The age is younger and people feel that they don't have options. They're trapped and there's no way out. And then they get an impulse. That's the problem with suicidal self-harm or completion, is it says, I've had it, bang, I'm going to do it. And that impulse is hard to suppress. And that is really what we need to go after in terms of prevention, so that people don't get to that point. So maybe Roger's point is that if we had a little less loneliness, maybe we would have a little less setting the stage for suicidal ideation, self-harm, and completed suicide.
Certainly. We all know that self-harm is not synonymous with suicidal behavior. We know people who do this who are not trying to commit suicide. They'll clearly tell you that. And very often it's a way of an outlet, granted not a very mature one, but an outlet for anxiety and stress. Things like that. Some studies have been looking at trying to model the effects of COVID-19 on suicide rates, and it's really fascinating. The predictions have ranged from 1 to 145%. That's not a very narrow band. So, Roger, why are predictive studies so variable, and are there any more models that might be more accurate?
Well, since we're citing some people today, Yogi Berra said what predictions are difficult, especially about the future. So by definition, it's difficult. And again, this point about suicidality, here it is 2021. We still cannot accurately predict suicide, not just from a public health perspective, but in the ER before we send a patient home. And every clinician, I think, is fully aware of that, unfortunately.
Certainly true.
That being said, so what you have, though, is you do have guiding principles. And for example, we do know that, yes, you can't predict suicide. There's over hundreds of factors associated with suicide, literally. But there are factors, for example, social determinants, macroeconomic factors that are highly replicated. The best one being economic hardship. And this goes back to the father of sociology, Emily Durkheim, and the change in your social status linked to suicide. But there was an observation that I refer to as the 1% rule. And that is that after the Great Recession took place, 2007, 2008, and 2009, for every 1% increase in unemployment observed in Europe and Asia, there was a commensurate 1% increase in suicide. Is that causation? No. That's actually one of many factors. Not one factor is causing this. But it is well established that a sudden and large economic shock is especially problematic from the point of view of suicide risk. Here's the part that's interesting, though, Andy, is that historically, economic hardship disproportionately affects middle-aged men. What's different about this situation, Japan has just reported the highest suicide rates in 3 decades, last 2 months ago. And it's especially hitting young people and hitting women. And when you look at the economy, who's been most affected? Younger people, people who work in the face-to-face economy, which is disproportionately women. And then women are at home with additional roles and responsibilities, with et cetera. We're hearing about increases in intimate partner violence. There's a whole host of factors at play here. So I would never believe that one factor led to suicide, but I'm convinced that economics plays a role here with respect to a risk stratification. And I think this is probably why in part. Now, we're talking about prevention. And what we learned from the Great Recession is that those governments, and Europe's a great laboratory because Europe has very different governments. Some are more liberal, some more conservative governments. So you have different economic policies. In governments of Europe, of Scandinavia, for example, that have liberal social programs, they actually reported that there was a significant attenuation of the risk of suicide if you invested in psychiatric first aid, if you invested in financial resources for people, forbearance on their obligations, as well as job retraining. So this is not ineluctably going to be the case, a fait accompli, that these things have to go up. There are resiliencies here. In some countries around the world are not seeing an increase in suicide, perhaps in part because of some of the social programs they have. That would be my hypothesis.
Yeah. Certainly talking about the issue of this affecting women and younger women more. In the United States, they're calling it a she-cession.
Yes.
Especially women of color have been quite affected. And if you think about it, you mentioned the multiple roles that women play, not only as breadwinners, but also now they have to be teachers for their kids who are home from school.
That's right.
Caretaking for others in the family. Steve, what can we do to help with this, especially the elderly and maybe the young women? What can be done to help protect these populations?
Identification of the stressors, mitigation of the stressors, and I suppose the easiest one and in concept might be to treat underlying psychiatric conditions. What we're doing here to try to help is this podcast. I know that we're going to be doing another podcast with a couple of my co-authors, Christine Moutier and Tony Pizzani, who we've actually written a book called The Handbook of Suicide Prevention. And in that, we're trying to get mental health professionals aligned to actually look at a prevention strategy by getting out and treating more or less depression. That's not going to solve everything, but to the extent that loneliness is actually a product of depression, I suppose that depression treatment will help. It's not going to treat loneliness directly because that's actually more complicated and, multifactorial thing. It's not necessarily a psychiatric condition. But I think the short answer is to identify and treat depression would go a long way and is the lower hanging fruit as far as I can see.
Yeah. We actually talked in our previous podcast episode, Roger talked about the difference between suicidal ideation, suicidal behavior, and completed suicides. And while they're related, obviously, they're not the same and they don't necessarily follow in line with prediction. So this makes it especially challenging, especially when you're talking about people with self-harm, as we talked about before, and the stressors that are going on. What can we do to recognize this, Steve, and try to do something about it?
You're right. If just really crude numbers, if 100,000 people in the United States do kill themselves every year, and a million have attempts, and 10 million have ideation and thoughts, how do we actually identify it? And we tend to approach it by looking at ideation and attempts as to try to get us to that. But only, in another way to say it, is only 1% of the people who have suicidal ideation complete it. So how are we going to find that 1%? And it probably means we're going to have to treat a group of people that are at risk. And certainly most people would argue that if you're having suicidal ideation, you're at risk for suicide attempts. And suicide attempts, you're at risk for actually being successful at this. I think that one of the things to do is to be able to talk about it and to be able to basically get it into help, get support. That if you're lonely, as Roger was saying, you tend to not share anything with anybody because you feel like you're isolated and nobody cares. So having access to that treatments, and we talked in another podcast, possibly if you have really impulsive, really scary types of ideation and plans, maybe a ketamine infusion will come in the future. But in the short run, I think it's just a matter of identifying and treating depression is probably the best thing.
Yeah, that certainly makes sense. There are certain aspects of dealing with COVID-19 that conflict with each other. And certainly if we're talking about the public health need at times to lock down, we know that certain countries have locked down certain states. Unfortunately, in the United States, it's a state-by-state issue. But the problem is when you have these restrictions and these lockdowns, certainly then the risk for mental health issues and even suicidal ideation increases. On the other side, of course, if you loosen the restrictions, you have the risk of spikes in the infection rate. What do you think, Roger, how can we balance these two conflicting kinds of imperatives?
They are conflicting imperatives. And the World Health Organization has a definition of health, and it is physical health, mental health, as well as social well-being. And I think that to save someone from the virus physically, only to destroy their finances, to lead to suicide, and they kill themselves, that cannot be considered a acceptable calculus. So it's obviously, it's a difficult, if not impossible balance. And I think what's added to some of the complexity is that according to the Pew Research Institute, we're at rates of mistrust in our society that have never been seen before. People are very mistrustful, low rates of happiness, and people reporting loneliness. So it's a really complex trifecta of factors here. And so I think, in fact, for me, what I've taken, I think we have to obviously protect ourselves physically, but I think that the mental health of the population stands to benefit greatly the faster we get these vaccines out. And so I think about vaccine not just against coronavirus, COVID-19, but I see it as a vaccine against mental illness. And I say that as a metaphor. Maybe it's more than a metaphor. Maybe it's literal if we accept viral hypothesis around mental illness. But the other part is that I think that, again, respecting public health recommendations and good common sense, but as soon as possible, get the children back to school, get the economy back open, because every line of evidence shows this is good for well-being and health. But of course, we have to respect public health recommendations. What I think we've all been concerned about is throwing babies out with bathwaters, where people say, the heck with it, I'm getting back to normal, my life. Like walking into a house that's on fire, you would never do that. And that's a concern. At the same time, I also think it's a concern when all we focus on is just protecting from the virus with no discussion about mental health. So it's obviously a balancing act. And but at the end of the day, let's get the vaccines out. Let's get things up and rolling again. But we've got to actually have fidelity to these public health recommendations.
PsychopharmaStahlogy podcast listeners know how effectively Dr. Stahl's books improve their understanding of a complex field. Good thing there are so many publishing this year. Like the 7th edition of the Prescriber's Guide. It's out now in paperback and spiral-bound formats and features 9 new compounds, injectable and transdermal formulations, and updated warnings and indications. Or the long-awaited 5th edition of his textbook, Stahl's Essential Psychopharmacology. It includes over 500 new or refreshed figures, an intuitive color scheme, 14 new uses for older drugs, 18 brand new drugs, and much more. Not to mention a new handbook, Suicide Prevention, with Christine U. Moutier and Anthony Pisani, Practical Psychopharmacology with Joseph Goldberg, and many more titles. Visit cambridge.org/NEI to learn more and get 20% off your order. It's really fascinating to me in America in particular. It's become so politicized. And there are people now, for instance, who are reluctant to take the vaccine, and they're making it into this, it's my right as an American to have freedom to not take the vaccine. Steve, what do you think of these kinds of attitudes?
You're right. You wear a mask. You're a Democrat. You don't wear a mask. You're a Republican. That's ridiculous. It's deteriorated into that. And both sides have points to make, as Roger said so eloquently. Mm-hmm. You know, the problem is that we don't think of the mental health of our country as, if you will, almost a capital asset that needs to be protected, just like real capital does, just in our businesses, and just the health of people do in terms of getting infected with a virus. We have not balanced the mental health as a capital asset against these other things, and it's nearly impossible to do so if we have the country pretty much split down the middle and mistrusting this. It's interesting. I work with the Department of State Hospitals in California, and we still only have about 80% of the patients in the state hospitals who have agreed to be vaccinated. And what's even more interesting is only about 60% of the staff have. It's starving in the midst of plenty here a little bit. If you got the vaccine and you don't get herd immunity, then all of us are still at risk. But this is mistrust. I think it comes out of probably a failure of leadership, both scientifically and politically. And those of us that are on this podcast should be doing our best to try to have some cogent scientific leadership so that we can give some facts out so people can make their minds up and do the right thing.
Yeah, that certainly makes sense. I also heard a recent statistic, a quarter of the Congress who had the earliest access and wide access have not taken the vaccine as well. And so to your point, these are leaders. These are people who we look up to. So I think that's potentially an issue. And what I worry about, too, is if we don't get to herd immunity, there's the risk of these variants coming out. And one of the things that we could touch on, I'm not sure we have enough time to delve into this fully. Roger, this is a virus that not only secondarily causes mental illness, but it's directly neurotrophic. It seems to have neurologic consequences directly.
That's right. And we have a long track record in psychiatry of pathogens, microbes being linked to mental illness. Of course, the classic was syphilis, general paresis of the insane, but there's endless examples of microbes that have either directly been, and of course, HIV certainly came to our attention 20, 30 years ago, and the list is long. What we've all heard about, what everyone on planet Earth has gotten a minor degree in, they didn't sign up to university for this course, but they all got a minor on immunology. Everyone's heard of cytokine storm. Mm-hmm. And along with the virus in its own toxic effects, we're hearing about people losing taste and smell. That's evidence of perhaps direct toxicity, but also the cytokine storm. We know that the immune system is a good guy, but the good guy could sometimes have collateral damage and could actually injure some of your own organs. And that could also be contributing not just to depression, but also this long COVID syndrome where people have lingering non-specific symptoms for many months. And then as well, in some cases, you wonder about some of the treatments people are taking, like steroids, high-dose steroids. And there's been a variety of idiosyncratic treatments people are taking that may also have effects on symptoms of mental illness in some cases. But I think that the lead candidates for me right now are the virus itself, as you said, being directly toxic to neuronal, maybe glial function as well. But the cytokine storm has been very interesting with respect to the impact, especially this long COVID syndrome we're hearing about.
Yeah, these long haulers may very well be manifesting what Roger's talked about for many years, which is the inflammatory aspect of major depressive disorder that's not related to COVID. So maybe they're actually intersecting here, and it wouldn't be surprising that if whatever triggers neuroinflammation during major depressive episodes is also occurring specifically in the brain because of COVID, it wouldn't be surprising that the consequence would be depression, for one.
Yeah, I just read a statistic that up to 50% of people have signs of depression up to 6 months out after COVID-19. And some of that, again, might be secondary, but some of it could be primary from the infection.
That's right. That's right. We've just put together a protocol for a study. We're hoping to start it in the very near future. And what we're going to do is we're going to take people who have that long COVID syndrome, which is not really refined yet, how to operationalize it. There's a group in Europe called NICE that is attempting to come up with a definition. But anyways, we're going to take these people who have long haul syndrome, long COVID, but don't meet the criteria for major depression. They don't have MBD. They have this, it's almost like a chronic fatigue, fibromyalgic syndrome. And they're going to get placebo for 8 weeks, or they're going to get an antidepressant for 8 weeks. And the theory is that the antidepressant might target some of the inflammation that's driving some of this.
Well, this is a terrific segue to something that we're going to talk about here. Before I get to that, I just wanted to mention also, in some people, it appears the virus induces a hypercoagulable state. And so certainly we have blood clots that could affect the
good point. Really good point.
Let's go down that road. Let's talk about, since we're talking about the intersection of the immune system and the brain and mental health, let's talk about a couple of recent studies that were published that I just find absolutely fascinating. And in one study, particular, was published in JAMA recently, adult outpatients who had symptomatic COVID-19 were given fluvoxamine, which is an older SSRI, and they had a lower likelihood of clinical deterioration over 15 days compared to placebo. How do we think that's happening? What's going on there?
Well, I'll mention possibly it's the sigma enigma.
One receptor.
One of the things that fluvoxamine has off target, other than being an SSRI, is that it stimulates sigma-1 receptors. And I called it an enigma because we really don't know what they do that well. But one of the things they do is regulate downstream cytokine production. And by the sigma action, it may mitigate the cytokine storm that Roger was talking about. That's a plausible mechanism, and there does seem to be some antiviral or at least antiviral consequence actions of fluvoxamine in mitigating depression in patients with COVID.
That's absolutely fascinating. And the sigma-1 receptor is an interesting history. It was originally called a sigma-opioid receptor due to some homology with opioid receptors, but it's since been found it's not an opioid receptor at all. And what about also the possibility of other anti-inflammatory mechanisms? We postulate that some of the ways that some of our antidepressants work may be anti-inflammatory. Roger, what do you think about that?
Yeah, it's been so interesting how the streetlight has shifted. I remember many years ago when I did more work in consultation liaison psychiatry, I would see a lot of patients who would be receiving interferon for hepatitis C and pegylated interferon, which I think it's established as one of the, if not the most depression-causing drug in the compendium. But when you prophylax these people with, for example, an SSRI, you cut the hazard in half. About 30 to 50% get depressed on interferon, pegylated interferon. You prophylax with an SSRI, you literally cut it in half. So that's really indirect confirmation, if you will, or of the cytokine hypothesis of depression. I think we know that depression is so incredibly heterogeneous, not just phenomenologically, but neurobiologically. But there seems to be a subgroup, and this subgroup is a group that often doesn't respond to SSRIs, who have inflammatory elevation and seem to respond to, in quotes, drugs that are anti-inflammatory or interventions that are anti-inflammatory, I should say. So it would be omega-3s, it might be L-methylfolate, it could even be exercise as an intervention. Some data supporting that as well. So this is interesting because, science is so much about streetlights and where they're shining. And I've always said we've had this high school crush on the serotonin transporter for decades. But I think we're saying, hey, there's things going on over here which we pay more attention to. And what Steve just mentioned around sigma and this study result, which has now been extended into an observation study where people have replicated this to some extent, it's pretty interesting. That speaks to very powerful, and in this case, maybe life-saving, anti-inflammatory properties. So I think it indirectly supports or instantiates this concept that inflammation is relevant to the phenomenology of what we're trying to treat in depression. And our drugs clearly have multi-purposes. And so that's sort of interesting. One of the related issues I've wondered about with this whole thing, many years ago, about 10 years ago, that's not many, but I'll call that many, the reports started to appear that if you have depression, major depression, and you go for the flu vaccine or varicella zoster or hep C vaccine, and you're a little older, it doesn't work as well for you. But if you take an antidepressant and while you get the vaccine, the seropositivity is better. And it'll be really interesting because our patients with depression and bipolar and schizophrenia are at higher risk of getting COVID and a higher risk of having complications.
That's exactly
It's really interesting whether our antidepressants or our psychotropic drugs, can they give patients better immune response to the vaccine, like they have shown with flu vaccines, varicella zoster, or hep C vaccine? That would be a pretty cool study.
That is fascinating. And you alluded to an interesting study that did show that patients with severe mental illnesses are at higher risk for infection. And I believe if you control for some of the socioeconomic variables, they were still at higher risk, which suggests
I think psychosis doubled their death rate if you had a psychotic illness. We know about that from the California Department of State Hospitals, where we're absolutely paralyzed with fear that these patients get sick because of all these socioeconomic factors notwithstanding, but also layer on top of that psychosis, which seems to be in itself a risk factor for death if you get COVID.
Yeah, that's really a very important observation. And speaking of observation, furthering this idea of antidepressants having more broad utility beyond depression. And I think you alluded to this, Roger. An observational study was recently published in Molecular Psychiatry called Association Between Antidepressant Use and Reduced Risk of Intubation or Death in Hospitalized Patients with COVID-19, results from an observational study. And this showed that patients given an antidepressant within 48 hours of hospitalization had a lower risk of death or intubation. And this association was seen with several antidepressants, including fluoxetine, paroxetine, escitalopram, venlafaxine, and mirtazapine. So what do we think is going on here? Apparently, there again is cytokines and other factors. One of the theories here was something called phiasma, functional inhibitors of acid sphingomyelinase activity. What do we think of that?
I think Roger's right that when you're in high school and you have a crush on the transporter, maybe it's time to start cheating on your boyfriend or girlfriend. Because I don't think this is an antidepressant mechanism. I don't think this is working because your depression's better, therefore your COVID outcome's better. This seems to be some pharmacological action for which we're not well aware. But the candidate mechanism staring us right in front of the face is some sort of anti-inflammatory, anti-cytokine action that's preventing, progression to intubation and death. Go figure. Roger, what do you think?
Oh, I completely agree. And I think what's both exciting and daunting is the inflammatory system, the homeostatic network. And we're talking about some of these targets like this acid sphingomyelinase, sigma-1. Those are robust candidates. But it's really interesting because these drugs target so many other systems within the inflammatory cascade or the immune response. And it's difficult to not get it complicated very quickly, but whether even we're looking at antibodies or cytokines or looking at even cellular systems, B cells, T cells, it's remarkable the effect that these drugs have. And one of the other areas which is related, for example, if you have a stroke and you have post-stroke depression, the literature shows that post-stroke depression prognosticates very unfavorable morbidity and mortality outcomes from a stroke. But if you have a stroke and you don't get depressed, you just had a stroke, and someone puts you on an antidepressant anyways, it turns out that your survival's improved as well. You don't even need depression to benefit from the SSRI post-stroke. And that's probably, you mentioned this as well, Andy, about the blood clots and so on. Mm-hmm. We don't say enough about these cell adhesion molecules and all these little molecules that make everything sticky. Mm-hmm. And so that's probably at play as well. I think it's really interesting because what's happened is, as I said earlier, the whole world's gotten a minor degree in immunology. And then some of the conversation on the 6 o'clock news, we're talking about spike proteins and all these haptogens and carrier molecules, adenoviruses on the 6 o'clock news. But also, I think what's happening is that, look, I think we're going to hear a lot more about inflammation and the biology of inflammation and how to treat inflammation. And it's interesting that our drugs, our psychiatric drugs, are in that conversation as anti-inflammatories.
Well, remember, too, that this hypercoagulable state is a very good candidate for some of the actions that you're talking about in stroke, and maybe even participates in some of the observation of less ventilator needs. And that is, don't forget that if your boyfriend is a serotonin transporter on a neuron, you've got another one on a platelet. And you can play with the serotonin on platelets and make, as we know, it can cause more bleeding, if you will, or at least risk for bleeding. And that might be a good thing in a hypercoagulable state where it's countering that risk, so that the ability to have not so much possibility of hypercoagulable leading to small strokes is occurring as one of the mechanisms of antidepressants.
Yeah, it's certainly true. This is a fascinating discussion, too. And Roger alluded to the fact that some drugs that are not traditional antidepressants have been shown to have some antidepressant activity. One that fascinates me, Roger, is minocycline.
Yeah, absolutely. It is interesting. Minocycline, it's a tetracyclic type antibiotic, been around forever. Mm-hmm. It does clearly have anti-inflammatory properties. And what's interesting is it also acts to stabilize your microglia in your brain, which is like your macrophage in your brain. Mm-hmm. And it may also, in fact, affect your gut biota. So it has all these different things that it could be doing. And so it has shown some antidepressant properties. I think that in 2021 going forward, I think that we've gotten a bit more clever about this. I think the notion that we just give one antidepressant or one drug for all and hope it works for all, that's yesterday's thinking. There needs to be some way to stratify people at the front door. And I don't think it's that far in the future anymore that we could have some type of stratification. In other words, I don't think we're ready yet to do a CRP protein. And then based on that, you're going to get either fish oil or fluoxetine. I don't know if we're there yet, that type of thinking, so to speak. But I really think now, given the way the technology is going, it doesn't seem unreasonable to me that we're going to be now looking at those types of ways to stratify patients.
Certainly.
Because there's no doubt about it that some patients do benefit from these types of anti-inflammatory approaches.
Certainly true. And one of the things I've done antidepressant trials for years, and people say, oh, there's a lack of innovation. I don't think that's true at all. I think the problem has been a lack of good biomarkers to identify these subpopulations. If we use the reuptake inhibitors, they're final common pathway drugs. You're flooding the brain with monoamines. Obviously, there's some people who need something further upstream, a little more surgical, if you will, and targeted.
That's right.
So, and biomarkers is fascinating because biomarkers not necessarily drawing blood from somebody. A biomarker could be a computer algorithm that analyzes your voice prosody, for instance, or other kinds of technological type signatures, neural signatures. I want to come back to something that we had talked about. I want to shift back since we're really talking here about mental health consequences and suicide during COVID-19 pandemic. And we've obviously focused a lot on depression, but certainly there are other mental health consequences as well. Maybe we could talk a little bit about some of the other mental health consequences of this COVID-19 pandemic.
Yeah, I think that one of the great consequences is that we've seen really disjointed access to mental health care, and that's been a major problem in the public square. I'll say it that way. I think there's been a lot of disjointed care. There's been valiant efforts, heroic efforts with the Zoom type medicine, telemedicine, all that. Mm-hmm. But the reality is it has been quite disjointed for many, and that's been a terrible issue. I've had lots of emails and calls from colleagues all around North America saying, hey, where's all the patients? People are not coming to my office. People are staying away from clinics out of fear. I think maybe getting the environment, these types of things are in the air. People have a lot of fear. So at the systems level, that's an issue. And I think that when you look at what we're talking about, we've been focusing on depression and as we should, and suicidality. Here in Toronto, after SARS in 2003, there was quite a significant increase in post-traumatic stress.
Yes.
That was a big one here, especially with some of our frontline workers. That was a really big one. Mm-hmm. And I think that's one that we're probably going to see more of. And I think as we're hearing about from many sources, the increase in drug and alcohol consumption that's been going on, and opioid consumption going on, especially bad opioid.
Yes.
And I think we all saw the data that appeared just a few weeks ago that the trend for decreasing tobacco consumption has now stopped. It's now leveled off. Now, part of that could be because the vaping is no longer as popular as it once was. But there's a view that people are reaching out to these other sort of reward behaviors, so tobacco, drugs, alcohol, and these are other situations that we're looking at. And I think many states around America here, because the opioid debacle is a North American problem, and here in Ontario and in British Columbia, Canada, it just off the charts, the rise in opioid overdoses that are going on.
Yeah, I think you're right on the money, especially when you talk about PTSD. I worry about PTSD in healthcare workers, but also in patients who are surviving these really scary bouts with COVID-19, and certainly in family members who their loved ones pass away and they can't see them, they can't hold their hands.
Absolutely.
There was a video posted to the New York Times website very recently that I would highly recommend everybody look at, and it was a video literally shown through an ICU nurse's eyes. And it was eye-opening. It was absolutely stunning. And it got me thinking about this notion of the PTSD. And these people are just inundated and overwhelmed. They don't have time to process what's happening to them. So I really do worry about this. And I worry about long-term consequences, both neurologically and psychologically.
Well, Fauci was reported as having announced, I think it was yesterday, that he's now worrying about a second pandemic, not of the bug, but of mental health problems that's going to follow. Once we have herd immunity, then there's going to be a pandemic, he says, of mental health problems.
Yeah. And Roger, it's interesting you talked about the rise of virtual telemedicine, which was a very slow ascending trend before COVID-19, but obviously sharply accelerated. We've all learned how to do this. And there are certain benefits and there's certain downsides, obviously. Some of the benefits are that our no-show rates decline precipitously. People are always home. They're always available for their appointment. But also some of the softer side, the touch and the being in the room and the sort of supportive things are lost. I think, though, we're entering a hybrid world where we're going to now have a mix of live encounters and virtual encounters because people have discovered some of the convenience of this. I wonder what the consequences of that are going to be.
Yeah, and what's really interesting about that is that, and I agree with you, Andy, I think we're going to see more hybrid. And speaking for myself as a clinician, I had hybrid before this happened, but it's really more than I ever anticipated it's going to be hybrid in the near future. And there's many follow-up appointments that lend themselves to convenience and professional good practices by just doing it on Zoom. I have to say I'm still biased. I still prefer to see people in person, especially that initial consultation. I've been entirely virtual.
I agree.
And many of these initial consultations are over the phone. I don't even see the patient. So that's happening a lot.
Yeah.
The other part, which I think is really interesting, I had a conversation a week or two ago about patient regression. And we have some of our patients are prone to regression because of characterological disorders, et cetera, et cetera. And the very framework of virtual care, they're at home. It's a safer environment for them. That's interesting because we'd be interesting to look at the experience with more sort of people with disorders that leave them susceptible to this type of regression, which usually is a conversation with borderline pathology, but it's not just that. And so there may be some advantages for some patients to be seen in this way. And on a related note, these complex dynamics that unfold between care provider and patient, where boundaries are sometimes crossed, not just by patient, but also by provider. It'd be interesting to look at some of these dynamics as well with Zoom and how that may be safeguarding against some of those things. So there are advantages and interesting perspectives to consider. But I have to say, this is my own bias. I still like seeing people in person. And I think all those verbal cues, I can tell you before, I never thought I'd ever assess TD over a telephone before COVID started. But I had to assess TD over a telephone many times.
Yeah, we've had to assess for TD, certainly by Zoom and things like that. You can do it, but I totally agree. It's clearly suboptimal. And we're wired. Our brain is wired to communicate probably to a minority degree verbally, but to a majority degree non-verbally, and pick up on these cues. And who knows, pick up on somebody's electromagnetic field.
That's right.
So, Steve, what do mental health providers need to know, and what do they need to think about doing here to adapt to this situation and to try to help prevent suicide or assess for it more effectively?
Index of suspicion is one. Realize that people are basically under fire from all sorts of quarters because of this epidemic, and the mental health providers just also have to take care of themselves because the stress of our own problems can't really leak into our professional lives if we want to be effective. Taking care of yourself, and also...
Steve, that's a great point that we hadn't touched on that. That's a great point.
It's interesting. One of the best things for inflammation, Roger once taught me, is to exercise. Until we have a fully effective central nervous system anti-inflammatories, make sure that you and your patients exercise as well.
Mm-hmm. Yeah, certainly true. All critically important. We don't talk enough about that, about providers taking care of themselves. And again, I allude to this video on the New York Times website of this nurse who was saying, I don't have time to take care of myself. I don't share it with my family. I don't want them to know. I'm really worried about the effects, the long-term effects on our population here. We are coming to the end of the podcast, and I really want to thank you for a really wide-ranging discussion. We examined, I think, many different aspects of the COVID-19 pandemic and its effects on people's mental health and how it's going to manifest itself, what we can do about it. Certainly, I hope it's been helpful to you in the audience. I want to thank you, Steve, very much for your thoughts.
My pleasure.
And Roger as well. Thank you.
Always a pleasure. Thanks, Andy.
So thanks so much for listening to this podcast series, the PsychopharmaStahlogy Show. And please join us for our other episodes in the podcast series that we'll be posting every month. Thank you so much for your time.
This episode was brought to you by NEI Membership. The 2021 NEI Synapse Virtual Half-Day Series is included with NEI Membership. Become a member today so that you can register for free for any or all of the monthly half-days, in which Dr. Stahl and colleagues will spend the last Saturday morning of each month sharing cutting-edge research and clinical insights on the topics most relevant to real-world practice. Don't miss out. Become a member today. Visit www.neiglobal.com to learn more.